focus of my research. A couple of disclosures. I'm the chief researcher in Aviv Scientific, as well as in the Sagol Center of Hyperbaric Medicine and Research, and I'm also a medical director of a startup company called BrainSpace. So obviously, I don't need to tell you how much the real pandemic is actually stroke. This is the US. I know we have a very global audience today, but we know that this is pretty much the same overall the world. Very significant burden of stroke these days. We're talking about the statistics from 2018. It's even worse today. 1 in 6 deaths of cardiovascular disease was from strokes. We're talking about every 40 seconds a stroke, every 4 minutes death of stroke, and significant financial burden of that. And you all know the long-term impacts of stroke patients, whether it's motor or speech or cognitive challenges, behavioral changes. I just want to, remind the audience that for cognitive, we're talking about 50% of stroke survivors that for some reason I still see neglected a lot of times, and people focusing a lot more on the motor or sensory or speech therapy, and sometimes cognitive is kind of left outside the scope of rehab. The classic prognosis for post-stroke patients, as you all know, the classic one was said 90 days. Today, people are saying anywhere between 3 months and 6 months, and lately there are a couple of small publications talking about even up to a year, but the classic plateau of rehab is anywhere between 3 to 6 months, obviously depending on the severity of the dysfunction. A lot of new treatments are running through different clinical trials, people trying different factors, different stimulation, different stem cell therapy, virtual reality, mirror therapy, different physical therapy changes. If you look at the randomized controlled trials, we still don't have any data to support any of those. Great stuff are in development, but so far most of them do not show significant improvement more than the classic biological rehab that we see by the brain itself, obviously. In 2013, we published a randomized controlled trial when we took 2 groups of chronic stroke patients. All of them were later than 6 months from their stroke. Most of them were even 1 year after the stroke, anywhere between 1 year to 5 years after their stroke event. And we tested NIHSS, and ADL, and we saw that using our specific hyperbaric oxygen therapy protocol, we were able to improve all patients' NIHSS, but in the control group, we did not. And then when we crossed them over, we actually improved their NIHSS, very similar to the original treated group. Same results were also in the activity of ADL. We then also studied the cognitive function of these patients, and we saw that we can affect the memory function in the treatment group compared to the control group. So it's not only motor function that we can handle, but also the cognitive function. So then we wanted to know, and this is the focus of this study, was what about the rest of the cognitive domains and not just memory, but also does it matter what type of stroke and what is the location of the stroke of the patient. So our method here is a retrospective analysis of all the patients we treated in our center between 2018 to 2017. Those patients, the inclusion criteria, they had to have chronic neurocognitive injury to the stroke at least 3 months, and they had to do pre and post computerized cognitive assessments, objective as possible. Obviously, any other injury that is not a stroke, any other brain injury was excluded. For cognitive assessments, we use the NeuroTrax battery that provides you with normalized scores in each of those domains. You see here, using very classic tests. But the great thing about NeuroTrax is obviously that it's objective. We always had neuropsychologists in the room, but the patient is basically doing it by himself in front of the computer. And the retest validity of this test is great. What about the intervention? So we used 60 daily sessions. So that's 3 months of sessions, 5 days a week. And we have our own protocol of doing it at 90 minutes, 2 atmosphere exposure with 20 minutes to 5 air breaks, meaning they're breathing oxygen for 20 minutes and then 5 minutes air, back to oxygen 20 minutes, 5 minutes of air, and so on until they get to 90 minutes. This is our facility. This is the chambers we're using. We're using a multiplace. This is pretty important, and maybe we'll have time. I can touch it in the end, the difference between a multiplace and a monoplace, but meaning more than one patient can go in. Here we can actually have 14 patients at the same time. So they go in, we increase the pressure to 2 atmospheres, and the patient get an oxygen mask delivering 100% oxygen. So here's our patient flow chart. We started with 351, and we didn't have the stroke details in 58, and 14 had additional brain injury. We had assessment in 279, but 117 did not complete the post-cognitive assessment. So we ended up with 162 in the final analysis. We did different types of evaluation. So in the evaluation of the location, cortical stroke versus basal ganglia strokes, we had 127. And on atypical stroke locations and multiple, we had different numbers as well. Here are the okay, here we go. So here are the patient characteristics that you can see. Pretty much older adults, 60 years old, pretty classic. Most of them were males, again, pretty classic. We're talking about time of injury, so I know I told you 3 months was the minimal, but again, most of them were somewhere in the 2.5 years. Here you see that very similar to the literature, 75% is ischemic and a quarter is hemorrhagic. You see the different locations we have and the symptoms that the patient were complaining. Obviously, a lot of them were motor, but like the literature suggests, almost 50% of them have cognitive symptoms. So question number 1 we wanted to address, of course, is HBOT effective in the way we do it? So in order to evaluate it, we wanted at least 7.5 absolute increase in their domains. And this is a pretty strict cutoff. Usually in NeuroTrax, when you're talking about 4 or 5 points, that's a significant improvement. But we set it at least 7.5 absolute decrease. I can show later on why did we choose that cutoff based on literature, just to be more conservative and strict in our analysis. So if we look at what we found here, you see that 40% almost have a significant increase in their memory. Overall, cognitive is about 30%, attention 30%, motor and coordination about 27%, executive function a quarter. So pretty significant number of the patients, at least 1 to 3 or 1 to 4, have this very strict increase. So that's for result number 1. We see a significant cognitive improvement with a strict cutoff. Question number 2 was, does it matter if the patient has an ischemic or hemorrhagic stroke? So we matched them, and we saw that basically the patient gets similar absolute changes, except in information processing speed that actually improves even better with hemorrhagic strokes rather than ischemic. But other than that, most of them were non-significant changes. So and again, that's the only one that passed statistical significance here. So if I summarize these results, really not a big difference between ischemic and hemorrhagic. again, except processing speed. Question number 3 in the study was, what about cortical versus basal ganglia strokes? So here we didn't have any changes in the cognitive improvement. So both groups received similar cognitive benefits from the protocol. Again, nothing past statistical significance. No significant differences between stroke locations. For the last question, I wanted to know, does it matter if the stroke occurred in the right or the left hemisphere, or more importantly, the dominant or non-dominant hemisphere? Obviously, as you know, when we have a left-handed patient, we're not really sure what is the dominant side, but in right-handed patients, we are more confident that the left hemisphere is dominant. And I didn't have fMRI or WADA test for these patients. So in order to control that, I only took the right-handed patients and then splitted them to left hemisphere stroke and right hemisphere stroke. And what we see here, there are two differences here. One is in memory. So we see that the left hemisphere stroke had better memory improvement compared to right hemisphere stroke, again, in left dominant patient. And visual spatial domain also improved better on the verge of significance here in the left dominant patients. So that's kind of the results here, better memory and maybe visual spatial in the left dominant lobe. Also, we did some regressions here, and what we found that the pre-injury score, the cognitive score, was the only significant predictor. Age, gender, medications, comorbidity, stroke type, stroke location, and time were not significant predictors. And I'll do a quick discussion here. So we know, obviously, today, compared to 20 years ago, that there is neuroplasticity, and we know what are the requirements for improvement of brain function following a stroke. And the reason, and I think that's the critical part here, is how do we select patients for our studies? And that explains why we don't really see that much of a difference in brain location and brain types. The reasons is when we evaluate patients to do HBOT for them, we want to assess if we see something we call the chronic penumbra. We evaluate this with a SPECT on top of the MRI scan or on top of the CT in case of when they cannot do an MRI. We do a SPECT scan and we evaluate the metabolism area, and we evaluate for necrotic areas compared to what we call dormant or ischemic areas that are not necrotic. If we found these areas and we found them in areas that are correlated with their deficits and their cognitive deficits, then we consider them for treatment. If we see only necrosis or these areas are not in areas that can be helped, be correlated with cognitive or other deficits, we just don't go further with the treatment. So we call it the functional to anatomical mismatch. I want to see low function, low metabolism with no necrosis. So just a case example, this is one of a patient in the study. So here's a 62-year-old woman suffering from right hemiparalysis and aphasia, came to us 14 months after her stroke. We see that low metabolism, again, in the SPECT, here in the motor cortex, as well as in the left Broca area. And after treatment, we repeated that SPECT scan. You see significant improvement going from green to yellow. There's a significant change in metabolism, both in the motor cortex and the Broca. Not perfect, obviously, but significant improvement showing significant neuroplasticity. And indeed, that correlated 14 months later with improved speech and improved motor function. Limitations, obviously, we're talking about retrospective study. We did do patient selection for the treatment with our methods of functional to anatomical mismatch. So that's a significant, it's a limitation, but that's how it should be done. We didn't evaluate motor function in this study because it's so heterogeneous, obviously, and then no functional measures and no control groups in this study. If I conclude, hyperbaric oxygen therapy can induce significant improvements in cognitive function of chronic stroke patients in the late chronic stage. The selection should be based on functional imaging and baseline cognitive function rather than the stroke type or location. And we saw that it may induce higher changes in the dominant lobe stroke. I think I have another minute. So again, like I said earlier, we're not doing this. We're not doing a monoplace. These, and I'm sure you may have heard of these types of chambers. There are a lot of safety issues with this one, as well as issues of getting to different pressures and different oxygen levels. So the efficacy of these types of chambers remains to be determined. We are using the protocol that we published on, that we found that's effective in the randomized controlled trials, and not trying to manipulate it any way otherwise. Thank you very much. Opening up for questions.
Thank you, Dr. Amir, for your wonderful presentation. Are there
Thank
any
you.
questions for Dr. Amir?